Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. Hi, all you BTK listeners. It's Scott here. Want to talk a little bit about our colorectal surgery oral board audio review. With upwards of 50 plus high yield scenarios designed for colorectal surgeons by colorectal surgeons. The scenarios are 5 to 7 minutes long, a variety of tactics and styles. We also have a high yield commentary to each scenario. It includes tips and tricks that help you dominate the most challenging scenarios, in addition to practical, easy to think through, easy to understand teaching style that covers the most confusing, the most interesting, and the most basic of topics that we all face as colorectal surgeons. So we are confident that you will find this unique, dual format approach highly effective way to prepare for your test. Check it out, behindtheknife.org.
Hey everyone, and welcome to Behind the Knife. I'm Elissa Dabaghi, general surgery resident at the Cleveland Clinic.
And I'm Jared Hendren, another general surgery resident at Cleveland Clinic, and we're joined by members of our colorectal surgery team.
My name is David Rosen. I'm the section head of colorectal surgery at Cleveland Clinic, Fairview Hospital, and joined by a couple of my colleagues on my incredible team here.
I'm Ajaratu Keshinro. I go by AJ. I'm one of the assistant professor at the Fairview Hospital, one of Dr. Rosen's partners.
And I'm Joe Trunzo. I'm one of the associate program directors for the general surgery residency program here at the Cleveland Clinic and part of the Westside colorectal team.
All right, great. So the topic we're discussing today is the management of acute uncomplicated diverticulitis. Why are we still treating these patients with antibiotics? There's been so many studies and randomized controlled trials showing no benefit, though we've been doing this for years. A 2022 study in Sweden found that only 11 to 48% of patients were managed without antibiotics at 2 different hospitals, so clearly many surgeons are still managing these patients with antibiotics. But before we get into that debate on the literature, let's touch on diverticular disease as a whole. About 70% of patients develop diverticular disease by age 70. However, more recent studies show fewer than 5% of those with diverticulosis ultimately develop diverticulitis.
Diverticulitis is still a highly prevalent disease, in part just because of how common diverticulosis is in the general population, and it's one of the most common pathologies a colorectal surgeon manages. In the U.S., data shows there are more than 2.7 million outpatient visits and 200,000 inpatient admissions related to diverticulitis each year, which costs more than $2 billion. Most episodes of diverticulitis are uncomplicated, with only about 12% of patients developing complications related to their diverticulitis. And the management of uncomplicated diverticulitis without antibiotics seems to be a pretty controversial topic. Why do you all think this is the case?
So I think one of the problems is, when we're dealing with a disease process that we tend to believe is an infectious process, to treat it without antibiotics becomes somewhat challenging. And when you have a patient that comes in that's sick, that's ill, doesn't feel well, and basically telling them we're going to treat this like a cold and we're not going to treat them with any therapy other than just supportive career hydration, especially if they've had previous bouts of it and been treated in the past with antibiotics to feel like they've been treated better before. So sort of changing the thought process or the treatment pattern for patients is challenging, and for providers ourselves, it's difficult to change what we normally are comfortable doing to see them better with this disease.
I agree with Dr. Trunzo. As he pointed out, I think some of the some of the issues with the providers as well. Before we get called as colorectal surgeons, they already got antibiotics in the ED, they've gotten antibiotics from their primary care. So I think there is a disconnect in terms of changing practice with other providers compared to what is in our guideline. And I think some of our colorectal surgeons still haven't changed as well. So we definitely have that side of the table that needs to be changed.
Yeah, as my esteemed colleagues touched upon, I think a big part of the problem is getting our minds around the aspect of not giving antibiotics. And part of it with diverticulitis is there are too many diseases that are so prevalent that we know so little about. We manage this all the time, but the cause of it and the mechanism, the etiology of it, we don't completely understand. I think most people probably believe that there's a microscopic perforation with a episode of diverticulitis. And so if you were to have a microperforation of the colon and bacteria and gas and stool leak out, it's kind of a no-brainer thinking that in that infectious process, as Dr. Trunzo said, you're going to want to treat with antibiotics. I think what we'll see when we get into these studies is a lot of these can be managed without antibiotics because the body is controlling the perforation or the microperforation. Antibiotics, way I wrap my head around is antibiotics are probably better for managing systemic infection, which might be pretty low here. Similarly, if you are in the surgery in an OR doing a colon resection, you spill a little bit of stool, you kind of just clean it up and you don't give them extended antibiotics. So I think really what the antibiotics are good for are systemic illness or sepsis, and probably unnecessary in these localized, uncomplicated cases.
Great points. Let's go ahead and get into our journal review and case discussions, and we'll talk about whether or not we should continue using antibiotics for the management of uncomplicated diverticulitis.
Sure. So we'll start with the Dynamo study. This was a prospective, multi-center, open-label, non-inferiority, randomized control trial in 15 hospitals in Spain, with the primary endpoint being hospital admissions when comparing the treatment of uncomplicated diverticulitis with antibiotics versus just symptomatic management. Secondary aims included differences in ED revisits, pain control, and emergency surgery.
Yeah, and the inclusion criteria were pretty strict for this study. Patients aged 18 to 80 were included if they had a modified NEF score of 0 on imaging, no episodes of diverticulitis in the last 3 months, no antibiotic treatment in the last 2 weeks, no significant comorbidities, good symptom control in the ED, and a max of one of the followings when looking at vitals and labs. Temperature greater than 38 Celsius or less than 36 Celsius, white count greater than 1200 or less than 4000, heart rate greater than 90, respiratory rate greater than 20, or a CRP greater than 15.
All right, y'all, let's start with a more straightforward case. A 55-year-old female with hypertension, hyperlipidemia, presents to the ED with mild but worsening left lower quadrant pain associated with nausea and chills. In the ED, she is afebrile, her white count's 14, her other labs and vitals are within normal limits. On exam, she's soft, non-distended, and focally tender to the left lower quadrant. CT of the abdomen and pelvis revealed sigmoid wall thickening with pericolonic fat stranding, evidence of diverticulosis without evidence of abscess or perforation, consistent with acute diverticulitis. Now, let's open the floor for the debate. How would y'all manage your patients based on the Dynamo trial?
So I think for this patient, this is a classic patient who would be a very good candidate to manage without antibiotics. You'll hear from Dr. Trunzo, my colleague here, shortly as a counterpoint. And that guy loves causing C. diff. So he would probably give this patient antibiotics. But this patient fits within the criteria you see of the Dynamo trial. And this is a patient who doesn't have is not systemically ill. Yes, has a leukocytosis, but the CT scan does not show any gross perforation, any free air anywhere. No reason to believe that this patient hasn't successfully walled off any type of microperforation or disease process. So I agree I concede that it is difficult when a patient like this presents to the ER to resist the urge to not give antibiotics because the patient has had somewhat of a process that has caused them to come to the emergency department. But for a long time, it was hard to move away from open surgery to minimally invasive. And so it starts with us, Dr. Trunzo. If we're not willing to move the needle, who will?
Well, I concede that I do put in my fair share of C. diff patients in the hospital because of my over antibiotic treatment. But to your point, it is a challenge when these patients come to the emergency room and we are faced with radiographic findings of an inflammatory, most likely what we thought was an infectious process, and there's debate about that. But we know we're dealing with a perforation, and many of these patients, when they get complicated disease and have an abscess, we know there's a major infectious process going on. Here in this case, you have an uncomplicated episode of diverticulitis. I think Dr. Keshinro made a comment about this. Many times these patients have already been on treatment at home, or by the time they've even called us to the emergency room to see the patient, they've already gotten a dose of antibiotics. So it's always challenging to turn around and say, they're okay, just send them home with no antibiotics, and we'll have them check in with us in a couple of days to make sure they're proceeding without treatment. It's almost a knee-jerk response at that point to continue therapy and go forward with antibiotics to continue what likely has been started in the emergency room.
Yeah, Yeah, I believe Dr. Rosen and Dr. Trunzo both make excellent points. I think the way we can start to make changes is by being very selective about patients we are treating without antibiotics. For me, a patient without systemic symptoms, I think, is a great way to start. And I think the Dynamo trial has a very conservative criteria. So I think that's a good way to select patients. If a patient has an incident finding of diverticulitis, I think definitely don't treat with antibiotics. And then again, if they have no systemic symptoms, that's the good patient to educate on dietary changes and use of NSAIDs. However, if they have some other signs and symptoms, I think those are the patients that I would treat. So we do have to educate patients and reassure them that even though they have some symptoms, it will get better over 24 to 48 hours with liquids and ibuprofen or Toradol, whatever you give.
Okay, let's discuss the Diablo trial now. This study was published in 2010, and it was a multi-center, open-label, pragmatic RCT, which aimed to assess the effectiveness of the management for a patient's first episode of acute uncomplicated diverticulitis with or without antibiotics. The study's primary outcome was time to recovery during 6 months of follow-up, which was defined by discharge from the hospital, normal diet, temperature less than 38 degrees Celsius, and a VAS pain score below 4 without the use of pain medications, as well as resumption of pre-illness working activities, which was assessed using a daily patient diary.
Yeah, so patients were included if it was their first episode of acute diverticulitis and limited to left-sided diverticulitis. Modified Hinchey classification was obtained for all patients using a CT scan, and only Hinchey 1A or 1B stages or Ambrosetti's mild diverticulitis stage were included. So before we get into our case discussion, I think it's important for us to define what complicated diverticulitis is. How do y'all define complicated diverticulitis?
For complicated diverticulitis, I think already to establish things like stricture, fistulas, and free perforation where you have free air, those are complicated. I think the subtlety in what we're discussing are the cases where it's inflamed and there's a bit of fluid around it, there's an abscess. I think for me, like Dr. Rosen mentioned previously, if there's a microperforation and just mild inflammation or significant inflammation, but there's no evidence of phlegmon or abscess, to me that's uncomplicated. But once you start to get a pretty significant reaction from the body where there's an abscess, I think to me that's complicated, in addition to the strictures, the fistulas, and free perforation.
Okay, let's talk about another case which isn't as straightforward and discuss how it relates to the Diablo trial. Let's say we have a 62-year-old man with hypertension, hyperlipidemia, COPD, and poorly controlled diabetes who comes to the ED with a temperature of 38C, heart rate of 100, white count 13, and left lower quadrant abdominal pain associated with nausea and diarrhea. He's never had a history of diverticulitis, and the CT showed sigmoid colon wall thickening with associated fat stranding and a 2-centimeter pericolonic abscess in the setting of diverticulosis, consistent with acute sigmoid diverticulitis. No other abnormalities on imaging. So what do you guys think? Do you think this second patient has uncomplicated diverticulitis? And then how would you manage it?
So you're giving me a challenging one here to try to argue against antibiotics, but I will do my best. No, I really can't. But for me, this is a complicated diverticulitis, right? For me, the definition between Hinchey 1A and B is kind of where the line goes in terms of abscess formation for uncomplicated and complicated, right? 1A is a phlegmon or localized inflammation, 1B being a pericolonic abscess. Now, when you go through all of these trials, most of them that would advocate for not giving antibiotics to uncomplicated diverticulitis, it's kind of the ideal patient, right? It's the patients that are healthy, don't have a lot of comorbidities, are not sick, don't have a lot of systemic findings. Granted, about 10% or so of the patients in the Diablo trial had Hinchey 1B diverticulitis, so had complicated diverticulitis. So they did show, and granted that's not enough of a subset to really show a statistically significant difference, but they had complicated diverticulitis included in this that they managed without antibiotics with success. Now this patient has poorly controlled diabetes, has COPD, has a lot of comorbidities that would be, I think, really ill-advised to be the patient to manage without antibiotics. So I would call this complicated diverticulitis, and I'm glad you let me go first in this round because I can openly concede to Dr. Trunzo that in my practice, this patient would need antibiotics.
Yeah, I think this is one of those situations where you're going to have a hard time seeing the risk or benefit of no antibiotics versus giving the antibiotics in this scenario. There's just too many reasons why this particular patient may have a problem with non-medical therapy or more aggressive medical therapy. Treats the antibiotics as being the more aggressive form of medical therapy. If you eliminate all the comorbidities, I think for us as a surgeon taking care of patients with abscesses, it's still a hard sell, even though the study did look at patients with small pericolonic abscesses and were able to be successful in that small cohort. It is very challenging to wrap my head around not giving any therapy aside from just supportive care. So I don't know. It's hard to debate this for me as a clinician. And I think you're going to have trouble getting patients to buy into this as well. You have to sell this to them that you're going to be fine, that, you're going to go on with no treatment. But, these trials have been around. So this one particularly has been around for a long time, and it has not gotten a lot of, it's still really not well adopted, even after all these years it's been around and available for us to review.
To play devil's advocate, I would say in this study, in the Diablo study, 3% of each arm required surgery. So can you make an argument that you can observe the patient and see what happens in patient where only 3% of them required surgery? Yes, you can make that argument. But like Dr. Trunzo pointed out, I think for me as a clinician, it'll be hard for me to sit on such a patient, especially someone with this many comorbidities. I don't want to lose my window of treatment response to antibiotics. So I would definitely treat someone like this with antibiotics. But I can see the argument to observe such a patient, but in a very monitored setting. I definitely would not send this patient home to be observed at home. That'd be crazy.
And not to keep belaboring it, the idea of bringing a patient to the hospital without treating with antibiotics would be a very difficult sell. And then you start running into insurance related. Well, what are you doing for the patient? Just hydrating the patient? Is that enough to get the patient an admission to the hospital when you're not giving IV antibiotics? Then it becomes a logistics issue as well. That's a real life situation that you have to face with these patients. So when you're admitting a patient to the hospital, it really is a tough sell to admit and do no antibiotic therapy.
True. Yeah, so say you manage this patient without antibiotics and they haven't had any symptom improvement over the next couple days. Would you go ahead and start antibiotics then?
Well, let's make it not this patient per se. Maybe an uncomplicated diverticulitis, not with an abscess. The first patient that we talked about. Someone that we all agree could be managed reasonably without antibiotics. So then to your point, what Dr. Trunzo, how, if the patient's not getting any better, over the next couple of days, do you wait a week? Like, how long do you wait before you start antibiotics?
I think 48 hours is a reasonable target point to give and I don't have a lot of data to support that timeline, but I think after 48 hours, patients at that point are starting to have some frustration and it's like, I don't feel any better. You don't want to give me anything at this point. So I think you're going to start losing the patient and they're trusting you if you're not doing anything for them and they're not feeling any better. And then obviously you always have to have that sort of window of if you feel like you're actually getting worse, then they have to come back to the hospital and then initiate them, potentially re-imaging them at that point. Because now have you gone from an uncomplicated event when you first made the diagnosis to where now there's a pericolonic abscess that is formed. So I think you have to have some line in the sand, whether it's 48 hours or 72 hours. I think educating the patient about what that timeline is too, setting an expectation with them that we got to give this a chance. You got to get them to buy into this therapy and say, look, at this point, if you're not feeling better, this is the next plan. Because if they know that, then I think you're going to get more buy-in. If you just kind of like sell them out there, they're going to be fine without giving them some sense of what that threshold is. I think they're going to run themselves into. You're going to have some confusion and not an accepting patient of this sort of algorithm of treatment.
Yeah, I think 48 to 72 hours, I agree, is probably about right. And again, I think establishing the expectations for the patient is important. If they get worse over that time, maybe consider antibiotics. If they're not getting better after 40 to 72, I think that's probably the time I would as well. And of course, like Dr. Trunzo mentioned, if they're getting even more worse, you might need to bring them back in, get another CT scan, and see how if something has developed.
Yeah, really fair points. So let's discuss our last case along with the Avod trial, which was a clinical trial published in 2012 by the Dutch Diverticular Disease Collaborative Study Group. This was a multi-center randomized control trial in Iceland and Sweden that aimed to determine if antibiotic therapy is necessary for patients with CT-verified acute uncomplicated left-sided diverticulitis. Their main outcome was recovery without complications at 12 months, and their secondary outcomes included complications, hospital length of stay, recurrence rates, readmission rates, and a need for surgery at 12 months.
And patients were included in the Avod trial if they had acute left lower quadrant abdominal pain with tenderness indicative of diverticulitis, temperature of 38°C or higher at admission or within 12 hours prior, an elevated white count or CRP, and then CT confirmed left-sided acute uncomplicated diverticulitis with no abscess, free air, or fistula. Let's discuss the management of this last patient based on the Avod trial and how it would guide management in general.
All right, so for our last case, we have a 7-year-old male with hypertension, diabetes. His last A1C was 7.5%. No signs of end organ involvement. History of prior episodes of diverticulitis treated with antibiotics, complicated by a C. diff infection, who presents with persistent fever. So his temperature, low grade, 100.2 degrees, heart rate 95, white count of 13. On exam, he's quite tender to the left lower quadrant, but not peritonitic. The abdomen pelvis showed multiple rectosigmoid diverticula associated with wall thickening and adjacent fat straining with an extraluminal foci of gas anterior to the sigmoid, but no free fluid was noted. What do y'all think?
Okay, so this scenario is interesting in that I've actually seen this in clinical practice. Patient has had multiple recurrent bouts of diverticulitis, has now had issues with C. diff. So treating with antibiotics becomes this you have to be very cautious about when you are going to trigger a patient for any treatment of antibiotics for any type of infection. So if you have a situation where we do have, yes, there's a small extraluminal foci of gas, but if clinically speaking, we can try to avoid antibiotics and potentially avoid the risk of another recurrent bout of C. diff, I think this might be that interesting case where you could consider doing it. And I think it is one of those things you have to be very cautious about, keeping a close eye on them. Yes, they have diabetes, some other health conditions, but if they're not, in extremis, I think this is a patient you might want to really strongly consider avoiding antibiotics, because the risk of C. diff becomes sort of a whole nother algorithm. And actually, this is one of those situations when I have patients that are running into issues with C. diff after having recurrent bouts of diverticulitis that I'm talking more forwardly about whether or not they should have definitive surgery because of this underlying risk of them being on and off antibiotics treatments that are potentially going to run them the risk of recurrent bouts of C. diff.
Yeah, so Jared and Elissa, I didn't realize you guys were going to present an actual patient of Dr. Trunzo's that he gave C. diff to with all his previous antibiotic use. But I think that's great that we're putting this on the air for everyone to see. I agree. I think this is a patient you want to try to avoid antibiotics, right? But there are some comorbidities. Patient has diabetes, right? He's pretty tender, has a leukocytosis, low-grade fevers. So this is a patient, actually, I would consider doing surgery on while inpatient, because the patient is in a state right now where he's doing pretty well. But if his diverticulitis were to progress and become more of an issue, then you have to say, okay, well, does he start getting septic? Are you behind the 8 ball? And then the surgery becomes, 1, almost guaranteed to have an ostomy, and 2, become more difficult and a more prolonged recovery. So this one might be one that you involve the patient in. And I think probably what would sway me too is what were those prior episodes of diverticulitis like? If you had previous complicated episodes, I would probably especially be leaning more towards surgery. But I agree that antibiotics you try to avoid as much as possible. If he worsens and has perforates or has an abscess, then you're talking about draining it and doing antibiotics, and then you're gonna have a prolonged course. So it might be one that, depending on how the patient is and involving the patient discussion, I might do surgery on sooner rather than later.
And this might be an indication of me being a junior partner and not as comfortable as Dr. Rosen and Dr. Trunzo, but for me, I will have a hard time observing this patient for, whatever time period you think in 24 hours to see if he needs surgery. I personally will want to put this gentleman on antibiotics, and I'd rather give him C. diff treatment prophylaxis in addition to the antibiotics, rather than observing and see what happens. But I definitely agree that the element of C. diff makes this someone that maybe a surgery should be thought of sooner rather than later. If he feels medical management, in my situation, I would definitely operate this admission. However, if I can get him to outpatient so I can do it electively, get his A1C a little better controlled, that would be my ideal preference.
That's an interesting thought. Prophylactic C. diff treatment in a setting where you feel like you need to treat them with antibiotics. What would you what would be your preferable treatment that you would use as prophylaxis for C. diff?
UPL.
Vancomycin.
Mhm.
Oral vancomycin.
Oh, yeah.
I think that's a fair point.
Yeah, that would be my preference. But
Yeah, these are all really great points. And, we've touched on this, but, in the age of multi-drug resistant organisms and these superbugs, being antibiotic stewards as physicians is really important. Other than building the antibiotic resistance we're seeing, we also place patients at increased risk of C. diff, like we talked about, and the much rarer but possible risk of adverse effects like allergic reactions, SJS, stuff like that. For patients that fit into these inclusion criteria, the evidence from these randomized control trials has demonstrated that treating uncomplicated diverticulitis with observation alone has proved appropriate. But what about the patients that don't meet these exact inclusion criteria for these studies?
Yeah, good point, Elissa. Maybe we can come to a final conclusion of sorts when to prescribe antibiotics for these patients.
so for me, again, being the junior partner, I think I'll be a little more conservative in terms of patients I don't treat with antibiotics. So for me, if a patient has incidental finding of diverticulitis, I would say that's fine. And then if they are otherwise healthy without any signs of systemic symptoms, I think that's fine. Even if they have some comorbidities, as long as they don't have any systemic symptoms, I think treating them without antibiotics is great. However, if they have abscess, high white count, concerning exam, I'm definitely admitting the patient, giving them antibiotics because I don't want to lose my window to treat them. So of all the trials, I think for me, Dynamo has kind of the criteria that I would like in my clinical practice. And then, last comment, definitely we need to, as colorectal surgeons, drive the change in the field and educate the other colleagues.
Yeah, for me, I think that any patient with uncomplicated diverticulitis who does not have any signs of systemic illness is a good candidate to avoid antibiotics. Now, if they have multiple comorbidities, you might think about, otherwise, but I encourage everyone to not pretend the comorbidities are more significant than they actually are as an excuse to give antibiotics. A little bit of hypertension is probably not a good reason to give antibiotics. Saw our patient that we talked about earlier with uncontrolled diabetes and COPD. Sure, I'm not trying to talk you out of antibiotics on those. But I think also, these patients really need, most of them, we touched upon it earlier, have been getting antibiotics for treatment of a lot of these episodes their entire life. And it really takes some time to sit down and talk to them and explain the whole etiology and walk them through why you're not giving antibiotics. And I think it's important. A lot of times, we're all busy. We got patients waiting. We're running behind. There's an add-on case we have to do. A lot of times it's a lot easier just to prescribe the antibiotics and get out of there 3 minutes earlier. But I think we have to take it upon ourselves to really try to push the envelope. And, I'm not saying you have to go cold turkey at once. Try with a couple patients. When they do just fine, recovering from their uncomplicated diverticulitis without antibiotics, you can let me know, and then you can continue to push the envelope even further.
So I found that for someone who's been around doing this, the non-antibiotic therapy has not been well adopted. But just from our discussions alone and reviewing these cases for our discussion, I feel like it is an underused tool, especially for these uncomplicated cases like Dr. Rosen mentioned. And I think we need to be better stewards of this, idea that we can be treating less of these patients with antibiotics and get a good result. And I think it's going to take a sort of a collaborative effort with us and the patient and educating them that we are using this with good, scientific support, that we can use this approach. But I think it's still important to set some boundaries and some sort of where we are going to start and stop treatment so that they know that we're not ignoring them or not ignoring their symptoms, that we're actually doing this thoughtfully. So, with that, I'd like to thank you all for listening in. That'll be the end of our discussion today. And thank you again for tuning in, and dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.